Hello, good afternoon, everyone. Um, Welcome to our AHIN Hour, or bi-monthly webinar series, where we feature topics on e-health, health information systems, and information technology for civil registration and civil statistics. Our webinars are recorded via WebEx and will be made accessible online after the session on the following pages: ahin.org, ahin.org. Before we start, here are reminders, the platform, how to participate, and the email feedback. We're using Cisco WebEx Event Center. If you're having troubles joining, log out the session and then join through the link sent to you by WebEx or by entering the meeting room number 866-284-975 and password is Sydney123. Your mics are muted throughout the meeting, but you can chat your thoughts to us through the chat tab. And for questions, please type them in the Q&A tab. Our speakers will answer them after the lecture. You will also receive a survey after the session. Kindly answer it so we can send the resources of this meeting to you. Today we have Professor Pradeep, Director of the WHO Collaborating Center on eHealth at the University of New South Wales, Australia. He is the founder of the Asia-Pacific Ubiquitous Healthcare Research Center, aimed at conducting research on the development and evaluation of ubiquitous healthcare using emerging technologies, such as the mobile broadband communication technologies. He's led to completion several global initiatives, such as the WHO research on the assessment of e-health for healthcare delivery, involving a number of countries in the Asia-Pacific region. ITUD/IEEE Mobile eHealth Initiative for developing countries, and the Global Longitudinal Study on the assessment of mHealth. He was also involved in the Rockefeller Foundation Mekong Basin Disease Surveillance Project involving Thailand, Laos, Vietnam, Cambodia, and part of China. APOC has been involved in several international initiatives on the application of mHealth for disaster management, such as Indonesia, Sri Lanka, Bangladesh, Papua New Guinea, and India. Professor Pradeep was the chair of the IEEE Technical Committee on eHealth and the founder of the IEEE Healthcom, that is now the forum of discussions for the IEEE/ITUD WHO initiatives on eHealth and mHealth. We also have today Professor Fabio Casati. He is Professor of Social Informatics and Senator at the University of Trento. Until 2006, he was Technical Lead for the Research Program on Business Process Intelligence in HP USA, where he contributed to several HP commercial products in the area of web services and business process management. Then he moved to academia, where he started a research line on technologies for happiness and life participation, focusing on achieving direct positive impact on society, and specifically on older adults. He is co-author of a best-selling book on web services and author of over 200 peer-reviewed papers. We will now pass on the presenter controls to our speakers. Hello, Professor Pradeep.
Yeah. Thank you, Cha. This is Pradeep Ray, and I have here with me Professor Fabio Casati, who has come from Italy on a visit to our university, and I'm glad that you could join us in this webinar. So what I'll do is I'll give you a brief overview of what is happening in the area of aged population worldwide, and particularly in the Australian context, in the Asia Pacific region, and how mHealth or mobile phone based technologies can help us in this process. So we go to the next slide. The agenda consists of a brief background of mHealth, followed by the various aspects of aged care, starting from the residential care coordination, the management of falls by the elderly, management of medications, and using the assistive technologies. Sorry? Yeah?
Hello. I'm sorry, we can't see your slides yet, Professor Pradeep. Can you click share and share my screen?
Sorry?
Yes, can
Can
you
you
please
hear?
share and share my screen?
Share, right? Just a sec. Share my screen.
Yes, there. It's loading now, Professor Pradeep.
Is it okay? Can you
Yes.
see my slides?
Yes, it's loading now. Thank you.
Okay, so basically, we need to be considering the role of mobile phones or mobile smartphones in the different aspects of aged care. One of them is for the residential care coordination or care coordination in nursing homes. This is followed by the management of falls. As you know, the elderly people have the suffer from very low quality of life in the event of a fall. And then we have got the management of medications that the patients can be taking, and of course followed by assistive technologies such as the using mobile phone based devices. We will also be talking about the European Union's Victoria Home project, where we are going to see the role of telepresence robots for home based care, and also we are considering an evolving new model called SILVERCARE for aged care delivery, involving innovation in social as well as healthcare aspects. So you can see here there are the whole thing started with the Australian Council of IT based aged care, and they had, when we looked at the problem of aged care using eHealth, 4 themes came up quite clearly. Number one is about the communication and information exchange for caregivers that is much more pronounced in the residential care context, where the care coordination has to happen not only with the care workers but also with various types of specialties such as geriatricians, such as nurses, such as physios, occupational therapists, and so on. And also there are issues about management of medications that comes up very clearly in this theme 1. The theme 2 is about medication errors, so that people do not take the same medication multiple times or forgetting to take the medication. That is quite common with the elderly, and therefore we would now devices are coming up to help solve this problem to some extent. And the third theme is very important for the elderly, is about the fall. A lot of doctors have told us that an elderly person at the age of 90s can be quite fit until they fall, and after the fall their quality of life deteriorates very fast, and also subsequently they probably would die also in the process. And therefore fall prevention and providing alerts to carers is extremely important. And the last theme is about older adults as consumers of IT, that is the range of new assistive technologies such as electronic games that can be used now for the help of the elderly. For example, rehabilitation from stroke is one of the examples where these assistive technologies such as games can help the elderly people to perform their exercises much more with entertained fashion rather than doing it repetitively, and also this can be connected with through mobile phones to their physiotherapists or occupational therapists, who can then subsequently look at to what extent the person has complied with the instructions for the exercises. So having described these 4 themes, I'll then go into the details of that. Probably the first slide is quite straightforward. Why mobile health? Why not e-health? A lot of people ask this question. In developing countries particularly, the rapid proliferation of mobile phones is improving the healthcare access, and of course the familiarity of all sections of population. One of the major problems in technology usage in any sector in particular in the healthcare sector, is the acceptance. The technology has to be accepted by health professionals, administrators, and the patients. And therefore, because mobile phones are now being used by everybody, the technology acceptance is also much simpler. And lastly, of course, the affordability of mobile applications in resource-poor settings for weaker sections of society. For example, we have been working with, for mobile health for TB in India, which affects the poorest sections of the population that cannot afford a phone for every member of the family. And on these situations, mobile health hopefully will help cause this the problem of affordability. This is an example of residential care coordination. As you can see here, at a platform, there are a number of platforms emerging in this field, and they have to coordinate between different types of people, the specialists, the hospital staff, nurses, the general practitioners, allied health professionals like physiotherapists and occupational therapists, the pharmacy people, and then you've got dementia workers, the family-based carers, the patient, and ACAT is the symbol for Australian assessment of aged care. And through that, the nursing homes decide who can be admitted and to what extent they have to pay for their treatment or their care in the nursing homes. And this is one of the typical examples of pre-admission. Before the patient can be admitted, they first give a referral for residential care. Typically, it comes from their GP, general practitioner. Then they would be needing some kind of a help in terms of conducting the assessments. We call it CPAT in Australia. Different countries have their different rules for this. And based on that, the patient is told how much they have to pay or whether they are eligible for this support or not. And once they are eligible, then the next stage is to booking the room for that person. So that's an example of how the pre-admission scenario would work. Similarly, there are scenarios for actual patient care, scenarios for discharge, and so on. Now, the first problem we are going to face is about the fall. How do you prevent the falls? And some of the data we have got shows that expenditure of hospitals admitted patients due to fall and related injuries above 65 years is estimated to be $106 million in the case of Queensland State, Australia. Hip fractures are the most frequent type of fall-related injury, and so many people above age 65 and around 10 people every day were admitted with a hip fracture. And at an average cost of about $15,000 per episode, hip fractures accounted for nearly 50% of the total estimated expenditure of fall-related admissions. So you can see it's a very major issue, and if we can devise methods of mHealth-based solutions, that might be very useful. And there are three ways of carrying out this support for the using mHealth. One is the use of videos for surveillance of falls detections. Many nursing homes in US, Europe, and Australia have been experimenting with the way of supporting elderly people using cameras in their rooms, and so that way they can identify which patient needs support before the patient tries to exit from the bed and in the process falls. In Singapore, Alexandra Hospital tried a method called using mobility-based agitation levels. So the cameras can detect to what extent the person is agitated, and based on that, it can provide alerts to the nurses who can come before the patient tries to move out of the bed and falls. But there are major problems in this case. One is about the privacy issue. Obviously, nobody would like to be monitored 24 hours a day, and therefore, in that situation, the researchers in US in the Tiger Center, University of Missouri, Columbia, have been using silhouettes instead of actual photographs of through the cameras to prevent the to help with the privacy issues. Still, there are other issues that can lead to slow acceptance of this technology. The next aspect is, and also because it is in the room, and as soon as the patient is outside the room, the technology is not going to support. Whereas wearable sensors will be much better in the sense that person can carry it as part of the belt, and therefore the person can be monitored and anybody can come to support that. But there are challenges in terms of the form, sensor lifetime, comfort and convenience, etc., which need to be solved. And the last aspect is ambient sensor, where we are not photographing anybody, or we're not asking the patient to wear any sensor, but in this case, the ambient levels, for example, consumption of electricity or some kind of infrared movement sensors can help detect that the person has fallen. But of course, there's a problem of false alerts in this case, because there could be a dog jumping at the coach, and that might be taken as a false alert, and things of that sort have to be solved. So if we compare the three technologies streams in terms of the things like physical discomfort or strain, video analysis, there is no physical discomfort, but there is wearable sensors may require that. Ambient sensors also don't have any physical issues. Privacy case, video analysis definitely has a privacy issue. Wearable sensors, no privacy issues, and ambient sensors also have no privacy issues. Violation of the personal space at the home, again, video analysis has got that problem. The other two solutions don't have that problem. The function in terms of malfunction depends on to what extent they are being used. There are two measures in this case: dependence on battery lifetime, dependence on sensor placement, and dependence on sensor usage. Now that way you can see there are different dependencies on the functionality. And the self concept, symbol of loss of independence, there is no loss here, but of course wearable sensors you have to wear, otherwise it will not work. And the cause of embarrassment or stigma, that can be there depending on how the wearable sensor is. So with this, the person can decide, and one can provide different range of technologies for the prevention of falls or detection of the falls. The next one is about the medication adherence. As we said earlier, many elderly people forget to take medication or take the medication multiple times, and therefore there are now emerging devices which have got sensors on the caps of the bottles, and as they open or close the bottle, that will somehow give an alert, and that will give an example of how the elderly medication adherence can be helped. And of course, there are automatic dispensing systems are also coming up, which is particularly happening in the case of hospitals with the carts that will carry different types of medication, and also help the nurse to help the patient with that cart by doing all the checks simultaneously without doing it multiple times, by moving back and forth from the patient's bed to the office and so on. So some of the hospitals are now experimenting with the automated dispensing systems as well. And in our project, we have been using this pill dispensers, which are basically pre-programmed dispensers pill at pre-programmable times during the day, and consists of a movable carousel consisting of tablets. So all these carousels have got tablets, and when the dispenser sounds when it's time to take the medication, and it can also give kind of pre-recorded voice messages as well if required. This is the Victoria Home project. It's a European Union project that we have been working with 5 countries. They involve Norway, Sweden, Portugal, Netherlands, and Australia. And in this case, there are these robots, telepresence robots. They are also called avatars, not exactly robots in that sense, because all they have got is a tablet that is mobile, and therefore the family members of the patient or the inmate or the caregiver can operate the movement of the robot remotely using their own laptop or their own mobile smartphones or tablet, and then go to the patient and then talk to the patient through the screen here, and even discuss medication. And this has also got integration with false detection. They can that we gave you examples. They're using wearable false detection in this case, and this whole thing is currently under trial in 5 countries at 50 homes, most of them in Netherlands, about 30 of them, and various numbers in other 4 countries. And so this is an example of how an integrated system can help the elderly at homes. We still have to do a lot of work in the sense about the cost. For example, currently the cost of this avatar is quite high, and that has to be brought down if it has to be affordable to individual patients' homes. Now, having looked at the technologies, the next important problem we face is about the adoption of the technology by the elderly. One of the major problems, as we said earlier, is the elderly people are not technology savvy, and therefore if you provide them with the technology, they must be very easy to use in terms of the size of the phones, in terms of the usability, and also it has to be very, very robust, because if it falls once, it fails once, the person will never use it in the future. So these are some of the psychologies of the elderly people we have studied over the last 4 or 5 years, and we have been our research has shown that there is one model which is based on the Japanese research, and it's called SILVERCARE, where the elderly people in an area are supported through young retired people, relatively young retired people. Many Asian countries, people have to retire at the age of 60 years, and they can be quite fit at that age, and they can support the elderly people above 75 in their area. And that way, the companies that support the technology will not incur the cost of supporting the elderly, which is normally very high. And therefore, these coordinators, we call them coordinators, can help the elderly people and also help the technologies to for a better and more efficient utilization of the technology. So that's why, as you can see here, the advocacy of the elderly, and this is we are doing the trial in 2 places, one in Kalyani near Calcutta in India, and one place in Sunshine Coast in the northern in the Queensland, near Brisbane in Queensland. And so what we are doing is these people are being enrolled through the SILVERCARE model, and have been, some of them are quite tech savvy. They don't need that much of support, but others do require the help. And this is the beneficiaries, senior citizens of 65 years in India particularly. Here, most of them are above 75 years, and they live alone with a spouse or with a spouse above 65 years, and interested in enrolling themselves as beneficiaries in the SILVERCARE program. The function is that 10 beneficiaries or 10 elderly people are looked after by one SILVERCARE coordinator, and this coordinator is basically a retired person who does not have any other major issues in terms of their own health or their own financial position. Most of them are pensioners, so that way they can support themselves. And under normal coordinators, the coordinators are to communicate once in 10 days with each of the 10 beneficiaries, and more frequently as and when required. So these coordinators, they need to have ample time. Obviously, they are retired people. They need to be financially stable. They need not be worried about their own financial situation, and most of them do not have any children living with them to look after the children, and they possess a better understanding of the problem of age and know the area very well. And typically, when there is no issues, they conduct workshops once in a month on topics of interest to the elderly, such as Alzheimer's, how to prevent falls, better self-care, diabetes, hypertension, and etc. And they have been getting very good response to this. But the response, the early feedback shows that some of the elderly, in spite of all this, are not prepared to take up the technology, but some elderly have been galvanized into action because of this. And this shows a typical workshop in Kalyani near Calcutta, where people of different backgrounds are attending workshops, and also some of them attending from their homes using the tablets. So we provided them with 7-inch Android tablets for this, and they are being monitored from the tablet of the laptop or from of the coordinator. And the services, in addition to these workshops, are provided by KINSPARK, the organization, the NGO that runs the service, is emergency medical care, regular communication with beneficiaries, and also group activities to combat loneliness and awareness generation. Any questions so far before I hand over the mic to Fabio?
Dr. Pradeep, can first proceed with Professor Fabio's lecture and entertain the questions coming in.
Okay, fine. Okay, fine. Okay.
Here. Okay. Okay. So, thank you very much, Pradeep. So, with colleague Professor Maurizio Marchese, we're actually here visiting Pradeep, and we thought to kind of sneak into this seminar. And so basically, our group in Trento works on technologies for well-being. So the bold hope that we have is to be able to create technologies that help people to actually feel better. We focus mostly on people in later life, and the angle we take is mostly oriented to fight loneliness. So as you, I think, all know, loneliness is one of the most detrimental factors for health of people. Is based on lots of research, is as bad as smoking 2 packets of cigarettes per day. So it's something which is really, really bad. Somehow doesn't receive the attention from funding agencies or government that it should. And so we started to try to tackle the problem of how we can help people who maybe cannot really go out and meet people to at least connect virtually and feel a bit less lonely. And the problem we had here is not only that of creating an app that connects people because it's full of these apps. It was finding a way for an excuse for people to actually, you know, get the tablet, open an app, come online. Right? So give the people the occasion, the context, the motivation to do this. And so we did some research on this, and what came out was that a really good way to do so was to kind of create what we call a virtual gym, which is what you see here as Gym Central. A virtual gym is like the name says, a virtual space where people can go and can train and be physically active. And so basically what we did is we created a virtual environment of a gym, and through a tablet people can actually from home log into the gym, and they can see a representation of themselves inside a virtual room. And just like Pradeep said before, people don't really like to be seen on camera. Maybe they like when they're, you know, incredibly fit, young and beautiful. But if that's not the case, then people typically prefer to be represented by an avatar of some sort. And so we also found this, as Pradeep said. And so what happened is you are thrown into this virtual room, and you see a coach, like you see in the slide, and the coach performs the exercise and from home you can follow it. And if you also wear some kind of sensors, which can be as simple as a phone or like more complex sensors, you also can see yourself moving on the screen as you move really at home, right? And this gives you a kind of feeling of training with the coach. Right? There are also a bunch of mechanisms to communicate with your friends in the gym, to invite them. Not everybody can use this kind of text messages. We made it as simple as possible. Nevertheless, some people can use it. Some people cannot really type on the keyboard, so they wouldn't use this. But we offer to everybody some extremely simple way to do simple things, such as, for example, invite friends to come to a training session, right? So even if you cannot really maybe type or don't know how to type on the tablet, you still have a way to read communication from the coach and to invite your friends to say, hey, come train with us, let's be active, let's do something, right? And so basically that's what the application lets us do. A coach in the backend could monitor all the training of people. They monitor, if they train or not. They monitor the intensity of the training. They can also encourage you to, to come back to train if maybe you've been lazy for a while and these kind of things. And also, what the coach can do, can see your performance and can also increase the strength and the level of complexity of the exercises. And a particularly interesting aspect here is that what happens is that you, as a person training, have a personalized difficulty level of the training, but you stay trained in the same virtual room with the other, right? So everybody sees a coach which offers you the exercise at different difficulty levels, but you are in the same room with the others, right? So this is actually something that in a real gym you could not even do, right? It's like you have your personal view of the coach, you train at your own pace, at the pace which is right for you, but you're still virtually in the same room with the others. So you see the other avatars that move with you, but the exercise that the coach is offering you is at your level, at the level that your strength actually allows. Right? So that's basically what we had, and this started really as a simple thing. Then it kind of snowballed from there. We got requests from all sorts of countries to actually use it for all sorts of purposes. So right now, for example, in the Netherlands, it's being used as a rehab tool for certain kind of, both from falls, but also from all sorts of physical problems. We are testing this in different parts of the world, and the response we have is really very, let's say, positive. So whenever we do the experiment, we do this. We have a study group which has the full version of the app. We always have a control group which has a slightly different version of the application. So it's the same application, but without the opportunity to see other people in the room with you, right? And basically what we do is we ask people to train twice a week. And what happens is that in the group that has the full version, so let's say the social version, people actually train much more than twice a week. So they go there and they're very active in training, and they really have fun in actually doing this. In the control group, so without the social part, people basically tend on average to do the minimum that we ask them. So if we tell them to ask to train twice a week, maybe they are being nice and kind to us, and they do train twice a week, but not more, right? So, or even less. So you see really that there is this, the social dimension is really important and is motivating towards training. And if we also consider, and Sorry for the fonts were a bit crippled here. But basically, what this slide is showing is that in the group with the full version, we found a lot of tendency of people to invite each other to train, and so people actually train together in the room, right? So there is a very strong effect, which is given by the opportunity of inviting people to go to this virtual gym and training together, right? The data you see here are for the tests we've done in Trento, Italy, but the exact same results we have been having in Switzerland with an earlier version of the same technology. We're having them in the Netherlands, and we have now in progress study in Siberia. In Siberia we do summer study and the winter study, which are of course very different because in summer in Siberia people go out, while in the winter most elderly people are completely stuck at home. They really do not go out literally for months. And so we are studying the difference in the effect, but over and over we find the same effect that the training program works and is really sustainable and leads to a behavior change only if there is a social aspect to this. Right? And so this is the stage at which we are now, and we're going to continue the study and the test, and the application is actually being requested by lots of research groups. So if you also want to experiment in your country, we can set up the platform, and we'll be very happy to run studies with you. If you're interested to actually know more, you can go to gymcenter.net and you'll find how it works, downloads, and scientific papers that basically tells you about the science behind it, the results, and so forth. Okay, so that was it, and thank you very much for listening.
Great.
Any questions?
Professor Fabio. We have a question here for Professor Pradeep. It's from Dr. Sorayo. He's asking, what's the best solution to monitor elderly in low bandwidth network environment and utilizing existing sensors in low-cost Android smartphone that is applicable in rural areas in Indonesia?
Good question. You know, there are a number of sub-questions in this. First point is, what do you mean by monitoring? Because if it is for self-monitoring, such as exercises, you can easily do that now through mobile phones. Each mobile phone has got an accelerometer now, so you can easily do that. But if you're saying that from the point of view of the doctor, then you have to follow a protocol that is decided by the doctor. Many of the doctors have not yet been using the technology that much, but some people are using it. So basically, in terms of usage of mobile phone and sensors, some sensors are now available at low cost. We have been working with a company in Australia that provides monitoring for chronic illness patients by doctors remotely. And so what happens is that the patient can have these sensors at home, or the local community center or local school can have these sensors. I think the cost was found to be whole set was what $900. But then if it is shared by a population of 1,000 people in a community, that is quite affordable. And then the doctor has to be connected to that, which is pretty easy these days with mobile phones. And there is a company with which we have been working, and we are currently evaluating that technology in the context of Australia and Asia Pacific. If you send me an email, I can share with you more details.
All right, thank you, Professor Pradeep. Any more questions from our attendees? Okay, so the others might be typing their questions. I would also like, in connection with that, Mr. Pradeep, how do you really monitor the other patients? For example, yes, they have their sensors at home, but do you require them to visit clinics, or do you deploy doctors or other health workers to the area?
Actually, I recently completed a lecture series on this topic in Japan, and I was showing a video on this that clarifies these problems. What happens is that if the patient is new and the doctors in that case would like to see the patient face to face, but follow-up appointments can be easily done over the network using smartphones. Okay, and the system that we are talking about can be used for that purpose, and is now being trialed in a large-scale trial in Australia, and we believe it can be used in other developing countries too. But the major problem here is not technology. The problem is the agreements, the medico-legal aspects of the service, because every country has got its own legal jurisdiction, and therefore an Australian technology can be used, but it has to be adapted to the needs of that particular country. And of course, there are other issues like language, and those things also have to be incorporated.
All right, thank you, Professor Pradeep. I also have a question for Professor Fabio. The application earlier was very interesting because group activities can be very motivating since you're entering this virtual gym, right? But if we're talking about old people, usually how old are the people using these apps? I'm thinking how they study these apps on their own.
Yeah, that's a very good point. I actually forgot to mention this. So most of the tests we do with people who are 70 years old and over. In Trento, we had a slightly older population, and we had also subjects that were 95. I think the oldest was 102, the oldest person. And also one more thing that now comes to mind. So we conduct like a training session before we do this. And what we see over and over is that, so we actually measure the comfort and fear in using this kind of technology. So what we see at the start is a certain worry about not being able to use it. And we run the same survey at the end of the study, which is after 2, 3, or 4 months, depending on the study setup. And we found out that the fear is completely gone. So the application is intended to be used really by the largest possible class of people, including, like I said, very old people. If you can do more, then the application lets you do more. But at a very basic level, you just need to watch, right? And even it's even faster. So basically, it kind of adapts to the level of interaction that you can offer. But the interesting part is that people learn really quickly, even fairly old subjects, like I said, 90 plus years old. Although at start they say this is impossible, then after one session they learn really well. So yeah, so it's really designed mostly for older adults, including very old persons.
All right, thank you, Professor. I also have another question with regards to that.
Can't hear you. Sorry, Cha.
Hello.
Yeah.
I have another question for Professor Fabio. The gym is virtual, right? So everyone does it on their own homes? Or
yeah, that's correct.
I'm thinking, how do you monitor them? Do you also have sensors like what Professor Pradeep said earlier? Because what if I'm just saying that I did this, I did that? How monitor me if you don't really see me? Because I think you mentioned about having avatars earlier. How can you check
Yeah,
if I'm doing really well?
That's correct. So there are basically 3 levels. At the very basic level, you just log in, and the only thing that the application knows is that you are there, right? So it shows the avatar, but in this case, the avatar moves to give the impression to other gym member that you are there and you're active, but the moves are kind of fake. So it just follows pretty much the moves of the coach. At the next level, if you have a mobile phone in your pocket, then we can sense some movement, and because we know the exercise that the coach is doing, we can infer the kind of movement that you're making. So by combining the fact that we know the exercise that the coach is doing and the information we get from the phone in real time, we can find out a bit about how you're moving, and we extrapolate. In the most sophisticated version, you actually wear sensors, or you have the Kinect, so one of these two options. And in this case, we can actually be much more precise in understanding your movement. So the precision really is more needed like in the rehab scenario. So the team in the Netherlands who is using this platform for rehab, they use it in conjunction with sensor because they need a more precise description of the movement of the person, because they need to see whether the person is really training properly, right? While for the test we have done in Trento, we really just wanted people to, to get a bit active and social. So it really depends on the goal of why you're using the application. But there are basically all these three levels, like 0 sensors, we only know you're there, a phone with a standard smartphone, or actually sophisticated sensor that you put on your body, or the, let's say, Kinect.
I would like to add here that there is one project that we have been involved in on using Xbox games for rehabilitation of the elderly. Actually, there are two purposes. One, for rehabilitation as from a stroke or something like that, as Fabio mentioned. The other application is maintaining the driving ability, particularly in developed countries. The elderly people living in faraway areas dread the most thing is the loss of driving license. And therefore, one of our PhD students has been working on correlating whether a good driver is a good gamer, or good gamer could be a good driver, and stuff like that. And she has done the experiment on 40 elderly people in Queensland to see to what extent these games can be used. And also we have been trying to classify the games for different types of exercises, along with the physiologists, physiotherapists, and cognitive psychologists and neuropsychologists, etc. So they can identify from Xbox games which can be used for which purpose. And then the person can play the game themselves or with somebody of their partners in another country. Virtually they can play the games with them. So it can be an entertainment plus exercise at the same time.
All right, thank you for the input, Professor Pradeep. I would also like to ask, these apps, are they for free download? So I just download and use it. And how the sensors do I have to pay for it first, so I have the apps also, and then use them? Or if not, if they're not free?
The one we have is for free.
Cost me.
We just need to provide some backend support, so we ask people to contact us, but they're for free. So we can set up a gym, room environment, and yes, we're actually very happy if some of you guys want to use it, we'd be happy to help, both with training and setup. In fact, it's very easy to actually do it. So.
All right, thank you. Just one more question. You monitor these people using these apps, right? Do you have like a database of who are these people using it? How old they are, and how often should they visit clinics or hospitals? Do you have data like that? And where do you store them?
Sorry, can you repeat the question?
Sir, I'm asking if you have like a database for all this information that you're getting from the apps that people use. So how do you store them? Do you have like an own cloud?
Yeah, so with the cloud in the region where the training takes place because of the legal requirement. So we're not really getting any health data just to avoid much of the complexity. So we only store training data, and yes, so basically they're on the cloud. Yes, and there is one cloud per region. So for people training in Asia, in Russia, this by law has to be in Russia. For people training in Europe, that's in Europe, and so forth. But basically, we only store really very, very basic data. It's really only training data. So we're not really storing any health parameter, right? I think we are not even storing heartbeats and these kind of things. We do measure it, we give feedback to the person training, but any health data, we don't store it.
And actually, this is a very important point that you mentioned. We have been working in another European project called AU to EU, Australia-Europe joint project involving 7 countries. This is basically on health data sharing across jurisdictions or across countries. So what is happening is the elderly, one of the sites is Heidelberg Red Cross nursing homes. And the data from the elderly people is being shared by different companies in different countries in Europe. And therefore, it's very complicated to what extent the data can be shared. And so we have been using e-authentication, e-authorization technologies that currently exist with the various companies like IBM, Philips, NEC, etc. And they seem to show that the current technology can provide the best possible way of sharing this data. So basically, we do have technology to share the data, whether it is cloud or elsewhere, securely, as long as we know what data to protect and when.
All right, thank you. I think this is the last question from our attendees. Dr. Chanara is asking, could you provide trail app for testing, like a trial version?
Trial application for this.
Yes, it's actually the full application is actually ready, and we'll be happy to provide it. So if you just contact us, then we'll give you instruction to download the app, and we create a training center, a virtual gym for you, and then you can either use the training program that we have with our coach, or you can have your own training program built in.
Right. So they just have to visit gymcentral.net, Professor?
Yeah, and just then you find the email address, and then just contact us, and we send you credentials to basically download the application, and we'll create a virtual gym for you.
All right, thank you. So I think that's it for our session. Thank you for sharing your time and expertise with us, Professor Pradeep and Professor Fabio.
Thank you.
Thank you.
Thank you for everyone who attended this webinar. May we remind everyone to answer the survey we'll be sending after this session, so we can send the material to the session to you. Thank you, everyone. Thank you to our speakers. Thank you. Bye.
Bye.